I really hope that everything is fine now and you can hear me. The connection is really very poor. I'm still waiting. It's just loading. The internet here in Egypt is catastrophic. Can you all hear to me? Because I really don't know if it's working or not. Even the Facebook doesn't tell me if it's working or not working. The internet connection is so bad, I think. I see nothing. Oh my god. Are we live again? I think finally we are live again. Please guys, just put any comment to tell me that everything is good and you can hear me and you can even see me and everything's fine. Just say hi or just tell me that everything's fine. Alright, I think that we already wasted about 26 minutes from our lecture today, and I think it's because of the bad internet connection. And I really don't know what to say because internet connection here in Egypt is a little bit catastrophic, honestly. Anyhow, our topic today is about non-surgical retreatment, and I really wish that we have a big time for our lecture today because our lecture today is a little bit long. It's not a short lecture. We have a lot of information, a lot of knowledge we have to talk and to share. But anyhow, let's start. First of all, I will start with this video. This time it will be different. I will start with a video, not with the introduction that I'm used to do. Here in this video, I was supposed not to talk, just to show you in the first 5 minutes about this video. Here we have a case of a previous endodontic treatment with a periapical pathosis, and we have an abscess related to the apex of the tooth, and it was endodontically treated. And also we had this kind of metal post, and I will repeat this video again in the end of our lecture, but I'm just showing to you how we should make this kind of non-surgical retreatment. Oh my god, I can see here a round pair, I can see a high-speed contra-angle, I can see metal post, I can see you playing with some kind of ultrasonic taps in a direction I don't know, and here I can see that the post is starting to dance, and there is some kind of orange gutta percha or gutta percha inside the canal. And here with this ultrasonic tab, you are trying to remove this post from the inside the canal, but in a way, I don't know why you didn't grasp it easily and remove it. Why you are using ultrasonic? We are going to talk about all of that. And here with this Fanta or a rotary file, you are starting to put the file inside the canal, and here is pus coming out from inside the canal. Oh my God, what are you doing here? Is this a non-surgical retreatment? Is it just like that? We will talk about all the evidence-based knowledge about non-surgical retreatments and all the factors associated with this decision of non-surgical retreatment. Here you can see we removed a little bit some of the gutapercha, and then with such kind of ultrasonic, another type of ultrasonic device, you are starting or trying to remove another gutapercha from inside the canal, and then after that you are going to irrigate, and you can see some pus, you can see some blood, and still there is, yes, here a piece of gutapercha inside the canal, and you are starting to remove the gutapercha with the irrigation needle tip. Are you crazy? We will explain everything in the part of the lecture. Here, after the composite build-up, you can see the canal is clear, the canal is clean, and with another device of ultrasonic, you are starting to activate what you have inside the canal. Maybe it will be sodium hypochlorite, maybe. We will talk about everything in details in our lecture today, which is already began too late. The first time I want to increase the time of my lecture, the internet connection is still poor. Anyhow, now you are putting what sponge barrier? What is this kind of barrier or sponge you are putting inside the this premolar, and then after that you are using a carrier to put the MTA inside the canal, and then after that you will start to adapt or to apply another increment of the MTA, and you are starting to adapt this MTA inside the canal. Alright, so let's start our lecture today. I wanted to start it a little bit different with video. Now, if we are going to define non-surgical retreatment, we have three main definitions. The first one from the American Dental Association of Endodontics, which is a procedure to remove the root canal filling and to do cleaning, shaping, and obturation. And by the way, it's a very easy definition, but it's not complete or sufficient for defining this a little bit complicated non-surgical retreatment. We have another definition from Cliff Radel, and it's defined as a procedure or an endodontic treatment procedure used to remove the material from inside the root canal space and to address or to know what is the deficiencies or the repair or defects and to repair it. And this also definition is a little bit insufficient. For me, the best definition to define the non-surgical retreatment is the one defined by Carr. He stated that it's a procedure performed in a tooth. This tooth had received a failed prior attempt to make a good root canal treatment, and this tooth required further endodontic therapy to have a successful result. This is the best, in my opinion, definition to define non-surgical retreatment. But before all, we have to know the etiology of non-surgical retreatments. We have preoperative causes, we have operative causes, and we have post-operative causes, and we will talk just in a hurry about these causes a little bit. The preoperative causes may be incorrect oral examination, maybe misinterpretation of the preoperative x-ray. That's why I always say that preoperative x-ray is very important. maybe improper case selection, maybe you just want to treat a tooth that it's unrestorable, and you just waste your time and the patient time to treat a tooth which is unrestorable, and also inadequate sterilization of your instrument. So all these causes are preoperative. We have also operative causes. During your operation, we have this kind of access preparation, like perforations or even overextended preparation. And also we have some operative causes in canal preparation, like perforation, canal blockage, ledge, instrument separation. Also, if you fail to obtain the biological objectives, if you didn't make a good cleaning and shaving, and also defective obturation, these are the main causes during your operation. And also we have this kind of post-operative causes like trauma, fracture, and this is maybe a little bit related to the patient and his habits and even with time. So we have three kinds of causes related to the failure of the previous treatment. Now, if you are going to divide the incomplete treatment of a root canal system, it will be divided into two different types. First, when the working length stops shorter than the right working length of the tooth, as you can see in the left picture in the slide, and the other factor is overlooked anatomy if you have a middle mesial canal, missed middle mesial, or even missed MB2. And also, if you are going to talk about the inadequate root canal filling, you should know that inadequate seal may happen or occur if your canal filling was done while there is no dry canal. You made your canal filling in the presence of exudate. Maybe you made a canal straightening with transportation of the apical foramen. Also, you may use an ineffective filling technique, or even you are using the right technique but you did it incorrectly. If we are talking about non-surgical retreatment, we have to mention vertical fracture, as you can see in this x-ray. And I have to speak a little bit about the diagnosis and how to diagnose vertical root fracture, and I will talk more about this in the next slides, but I just want to mention here that if the fracture is in a coronal portion and you can see it under the microscope, it will be very easy to diagnose. But what if the fracture or the vertical root fracture is a little bit apical? In an apical portion, it will be far from simple to diagnose it. Alright. And the endodontic surgery in such cases will just be here done to confirm or to deny the root fracture, but it will not completely remove or treat vertical root fracture. So vertical root fracture is honestly our enemy in such non-surgical retreatment. Now we have to mention loss of coronal seal. In an evidence-based way, Magora and co-workers, they stated that the time that is only allowed for you not to do the non-surgical retreatment is 3 months. So if you have a tooth with even with the good obturation, and it was without a good coronal seal for 3 months or longer, for sure it will just need retreatment. So the loss of coronal seal is a very, very important factor we have to mention here. Now we have some factors affecting the prognostic or the prognosis of the retreatment decision making. Like, we should know the specific cause, presence or absence of the periapical pathosis, and let's talk a little bit one by one, because these factors is very important in your decision making. I'm not here today just to show you the videos or just to show you cases. We have a lot of cases, we have a lot of videos, but I just want to open your mind and put these very important factors to make you decide what is the right decision in non-surgical retreatment. unclear cause of failure, you will not be able to retreat a case if you don't have or if you don't know the clear cause of failure. So you should determine what is the cause of failure to deal well. I'm so sorry. And also the presence of periapical basosis. All the studies stated that if you have a periapical basosis or a periradicular radiolucency or a pathosis, it will decrease the prognosis of the case. Like, for example, Baker and co-workers, they found that the success rate was inferior in the presence of periapical lesion prior to retreatment. They found that the preoperative, if there is a preoperative X-ray lesion in the X-ray, the success rate is from 97 to 40%. But if there is no periapical basosis, the success rate will range from 100% to 84%. Also, the satisfactory quality of the previous treatment. It's a very important factor. When you have a tooth, you want to make a retreatment, you should know the quality of the previous treatment. Because if the quality of the previous treatment is good, success rate will be less because the previous dentist did everything or did everything he can do or even what should be done to the tooth. So, Shiving and co-workers, they reported that 88% success rate for retreatment cases in case of the prior treatment was unsatisfactory, but they found that the percentage is less, about 66%, when the prior treatment was adequate. So, if you can see here in this X-ray, the lower first molar, it's a great great white lines you can see in the X-ray, but it failed, and I did retreatment for this case, and we will see the prognosis after that. So maybe even if you have this kind of good, satisfactory quality of an X-ray, but it failed because, as we all say and as we all know, root canal treatment is not just about the white lines. Also altered root canal morphology, like ledge perforation, fault pathway stripping. Gorney and co-workers, they found that there is a very significant difference in terms of success rate between cases with altered morphology and cases without altered morphology. They reported about 84.4% success rate in the absence of iatrogenic alteration. And also, indeed, the periodontal involvement, even if it's primary period, like for example in some periodontal diseases with some degree of severity, and also even if we have a primary endo secondary perio lesion, like you can see here in the X-ray. And indeed, if you make a good root canal treatment in such cases, the periodontal problem will just disappear, but sometimes we need also to interfere periodontically to a little bit do some curettage for these pockets. And also the vertical root fracture, as I told you. And for me in my clinic, if I want to diagnose vertical root fracture, I will just start with the periodontal probe to check the periodontal probing depth. And if I have vertical root fracture, a little bit you will have this drop of the periodontal probing or narrow probing depth, very deep probing defect related to the root with the problem. And also there is a very important tab you can see when there is a sinus tract in an unusual location, like for example closer to the cervical part of the tooth. Because in vertical root fracture, I always see this kind of fistula near to the marginal or gingival part of the tooth. And lack of coronal seal, as I said before, if you have a lack of coronal seal, you will have less prognosis of the case. And indeed, the importance of the professional experience. You should have this kind of professionalism or this kind of experience in dealing with such cases, because in such cases you are involved with thinner root walls and altered anatomy, and not every general practitioner or even endodontist can deal with such cases, but a beginner in such specialty of endodontics will be very open-minded, but he will just require more time to be prepared to avoid this kind of damage or even deal with this kind of cases. And indeed, the available technology is another very important factor to affect the prognosis of such cases. At least you should have ultrasonic tap and also Kurdi. No, that's not Kurdi, it's a microscope or a magnification and the good illumination too. So ultrasonic and magnification or illumination, like a microscope for example, are very very important to be used in such cases. Here we have a study by Sitzer. He reported that a success rate of 1 year after doing a surgical endodontic treatment, it was 88% in the normal cases. But when he used the operating microscope and he used the modern techniques, the success rate elevated to, or was higher to, about 94%. This is evidence-based. I'm just telling here that operating microscope indeed, and using the modern techniques and using the good kind of magnification and illumination like this one microscope behind me, it will be very good for you to have a higher success rate in your clinic. Now, the last factor is patient expectation. And honestly, you have to make this kind of informed consent in your clinic that will protect you and also protect the patient. And you should explain and illustrate everything to the patient, the cause, the time, everything. You should tell your patient everything about the case, about the treatment, about the prognosis, about the success and failure of your case, of his case, or even her case. You should tell the patient everything, and then to make a good decision about the treatment plan. So now, as we before talked about the etiology of the failure, we have now to also talk about the etiological factors. If we are going to talk about that, we should place the etiological factors into just 4 groups. We have this kind of persistent intraradicular infection, or even extraradicular infection, foreign body reaction, and indeed true cyst. And if we are going to talk about infection, and if we are going to talk about bacteria, we have to mention these 2 very dangerous and bad bacteria. This Actinomyces israeli and Propionibacterium propionicum. These 2 kinds of bacteria, they prevent healing after the root canal therapy, and indeed they resist the immune defense and persist in the periapical or periradicular tissues, and always make it harder for any success. I just mean the 2 bacteria, and I think that they are 2 bacteria. Anyhow, now for the evaluation, we have clinical, histological, radiographic, as we always said, but histological here will not be very important. The important here is clinical and radiographically. Clinically, you should make a correct diagnosis. You should rule out all the non-odontogenic etiology. You should perform all the appropriate tests. You should interpret with the patient's responses to these tests. You should make a good definitive diagnosis and decide a good treatment decision or option. What are the clinical criteria of success according to Bender et al.? According to him, or to them, absence of pain and swelling, disappearance of sinus tract if there is a sinus tract, no loss of function, no evidence of soft tissue distraction. So all these criteria are the clinical criteria for success according to Bender et al. If you are going to divide assessment on a subjective and objective clinical assessment, in subjective assessment you should just know if there is a previous treatment where was done under a rubber dam or aseptic techniques or not. And objective assessment, just like visual extraoral and intraoral examination, magnification indeed will help, periodontal evaluation to exclude the vertical root fracture, for example, or even to know if the tooth is restorable or not, and percussion, bite, palpitation, bulbar vitality test, all of that is very important. What about radiographic assessment? It's obligatory. Sometimes even the normal periapical X-ray is not enough, and we need this kind of comb-beam CT. But you should make a radiographic assessment. You should evaluate the caries, know the quality of the previous obturation, if there is a missed canal, if there is any impediment to make a good shaping or instrumentation, if you have any periapical basosis. As I said, all these factors affecting the prognosis of such case. And according to the radiographic assessment, we have success and failure and questionable. Success, absence of apical lesion, or even a lesion present at the time of treatment, just resolve it, or even if you didn't have a lesion at the time of treatment, nothing happened and no development of a lesion. And of course, we will talk about when to evaluate in the next slides, but failure is persistence or even development of a radiographical basosis. And we have this questionable state, a state of uncertainty. State of uncertainty. We don't know if it's success or failure. We have a situation, for example, if we have a lesion and it's neither became worse nor significantly improved. So in such cases, we just follow up, and even for 1 year or more, we just follow up and see. But do not again, do not interfere or just to mix between a true cyst that need surgical intervention and lesions like that with a questionable prognosis. So please, because I saw a lot of cases with some great endodontists and friends that they want to just follow up for 20 or 30 years and there is a lesion. So do not mix between this and that. When to evaluate? First of all, after 6 months, and then 1 year, 2 years, 3 years, or even 4 years, up to 4 years to evaluate the success or failure of your treatment or even retreatment. Now, we finished this kind of open-minded discussion about the decision making related to the non-surgical retreatment. Now, treatment plan. If you are going to decide a treatment plan for such a case, either we do nothing, extract the tooth, or even to do a non-surgical retreatment, which is our talk today, and surgical treatment. Here I'd like to show you a video about non-surgical retreatment also. If you can see here, we have a very big lesion related to the distal canal, and we have a post here. And again, and I will talk about the post and how to remove the post. But again, with ultrasonic in a counterclockwise motion, because I saw a question in the comments, it's a counterclockwise motion, but because it's in the mirror, you think that it's a clockwise. No, it's a counterclockwise motion. With the ultrasonic, by the way, here in this case, I made a selective non-surgical retreatment. I only decided to retreat the distal root. I'm not here today to talk about this kind of very small amount or even very small to do this kind of non-surgical, selective non-surgical retreatment. But now you can see, after I just removed the post, you can see the pus inside the canal. The pus is just coming out from the periapical lesion related to this root, this distal root. And indeed, if you know this abscess drainage cascade, it's pus, blood, then exudate. After pus, here you can see a little bit pus mixed with blood, and then it will be only blood, as you can see. And with irrigation, you will just remove all the root canal fillings, and then as you saw the exudate, here is when the guttuberca was removed, and then in the second visit I have this kind of dry canal, so I decided to start my obturation, but the apex was a little bit open, so in such cases I always prefer to put MTA, and before putting MTA I just put this kind of supporting sponge cellulose. This one is from Coltain, and I put it and adapt it beyond the apex, and of course I know the length previously with the apex locator, and I adjust my plugger to the length, and then I put MTA, as you can see, with map system, because I'm really a big fan of map system in putting or apply the MTA inside the canal, or even in such very advanced cases of non-surgical retreatment, and then you can adapt your MTA inside the canal with the plugger gently, or even with a paper point, big paper point, and you can invert the paper point to use its head, and even with a brush, a pond brush, a composite pond brush. As you can see, we have two portal of exits filled completely with MTA, and in the second visit the patient came to me, and by the way, this patient is a very important, is a very famous VIP, and I should not mention anything more, but this patient is a VIP person. Anyhow, after that I did check the MTA, and after that I injected my thermoplasticized guttuberca inside the canal up to the orifice. And then after that the patient was fine and everything disappeared. Alright, because we don't have a lot of time in today in our lecture, now we are going to talk about the non-surgical retreatment. The primary goal of our non-surgical retreatment is to regain access to the periapical area. We want to regain access again to the area beyond the apex. I want to go again to this area and to clean and to drain anything if there is anything there, and to clean my root canal system more and more and more. The principles of endodontic therapy in such cases is good coronal access should be completed. We should remove all the root canal fillings that was before, and we should, any canal obstruction if we have, we should manage, and any impediment to achieve a good shaping for the full working length must be overcome, and indeed cleaning, shaping, and effective obturations. This is the principles of any endodontic therapy or retreatment. First of all, the axis here, or the retreatment axis here, is simply called or nominated as coronal disassembly, because we want to remove this kind of coronal restoration, like a full coverage or even a core buildup, like composite or even amalgam restoration, and even if we have a post, we should remove it. So it's advised to remove the existing coronal restoration when, if you have a poor marginal adaptation, if you have a secondary caries, to avoid procedural errors, and also to maintain form and function and aesthetic, and to make a good coronal seal after that. But it's advised to leave the existing restoration and to re-access from it if the restoration is functionally designed and well-fitting or even aesthetically pleasant. And in some cases like that, if we have a periapical lesion, in some cases we go to the surgical treatment option. But if you are going to decide that the non-surgical treatment option is more conservative and you have a good functionally designed restoration and a well-fitting or even aesthetically pleasant, you can just re-access through them. Coronal disassembly devices, we have this kind of grasping, percussive, active. I'm not here to talk about all of that, but I just want to warn you, do not use this kind of percussive instruments, because I know that everyone in his clinic has this kind of percussive instrument to remove the crowns or to remove any kind of prosthetic restorations, but this is very, very harmful to the periodontal ligament, and please do not use percussive instruments. Now, about the post removal, because everyone in the videos want to know how to remove post. It's not only ultrasonic and moving a counterclockwise. No, we have a lot of factors affecting this post removal, like your judgment, training, experience, technique, devices, the post type, the cementing agent. So we have a lot of techniques for the post removal, ultrasonic or even rotosonic and mechanical, and here today I'm going to focus on the ultrasonic vibration because this is the most common way to be used in removing metal post inside the canal. So the steps. You should remove first the core restoration material with a high speed pair or contra with pair or even a stone, and then a less aggressive instrument like, for example, a slow speed handpiece or even this kind of ultrasonic taps with diamond particles around it. You can use it to remove a little bit this remaining part of the core restoration around the post. And then magnification, indeed, and illumination is very important. It's a very important. I'm so sorry, I'm a little bit tired today, and anyhow, I just lost my way. Anyhow, all right. And magnification and illumination indeed will help us to make a good treatment or even a good way to remove this post. So, to be minimally invasive and removing this kind of post, to minimize the risk, to not do thinning for the post, because the more the post is left, the more the options for removal, and also the more the tooth structure is left and saved, the more the options for the restoration. So it's not only the contra or the handpiece, you are just removing tooth structure or removing whatever you remove. No, it's just only that you should know that more post is left, more options for removal of the post, and also more tooth structure is left and saved, more option for restoration. Alright, so if you are going to use the ultrasonic vibration, indeed we are all have these kind of piezoelectric ultrasonic systems in our clinics in conjunction with a specific instrument or even specific ultrasonic taps, and then you are going to use these ultrasonic taps in the interface between the post and the tooth, and you will just move in the circumference of the post in a counterclockwise motion to a little bit disrupt the cement structure or the cement structure around the post. And then I have to tell you one very important tap. You should remove your ultrasonic tap in 10 to 15 seconds. If you are just activating the ultrasonic for 10 or 15 seconds, remove it again. And this is very important. Why? To allow the use of air-water syringe to cool the whole down system, to cool down the whole system, to clean the area from the debris and to reduce the temperature. because it's very important. In an evidence-based way, I will just mention that one study showed that the heat generation of the ultrasonic and the vibration, it will help to decrease the retention of the resin cemented post. But you should know that the heat generation will just damage the periodontal ligaments. And as I said in the last lecture about the heat generation of the ultrasonic, this kind of 10 degrees increase, and it was in the past a little bit catastrophic, but nowadays it's a little bit safer even in these 10 degrees. But be careful not to increase the heat temperature. So, as I told you, if you are working with the ultrasonic, and indeed you will use it without a coolant first to enhance your vision and to see, you just stop after 10-15 seconds to cool down the whole system again, and then again. As you saw in the video in the first, in the beginning of the lecture, I used the and you will see it again. I used the ultrasonic without coolant first, and then with coolant to cool down the whole system. Now, for the gutta-percha removal, and this is very important because after we remove the post and after we did talk about the post, now it's time to talk about the gutta-percha. And for the gutta-percha, I just, because a lot of people asking me about how to remove the gutta-percha, I will just divide the root canal into 3 parts: coronal part, middle part, and finally the apical 1/3. And here I had to mention this great Fanta retreatment kit. They have this kind of files, 3 files. First one is 3009, second one is 2508, third one is 2007. And by the way, this instrument or these Fanta files are really different from any other files because the tab of the file is active. So please be careful when using them, but they are really great in retreatment and in removing the gutta-percha. And I always use them in straight canals, like for example in a distal root of lower molar or even a palatal root in upper molars. They are really great, or even if you have a big canal, straight canal, they will be very, very, very good to remove the gutta-percha from inside the canal. So what about the curved canals? What about other small canals? I will just tell you what. But here, before we move from this part, I will just mention, yes, here, my gutta-percha removal technique and protocol. I always remove the part of the gutta-percha in the coronal 1/3 with the first file of retreatment kit, or even with an orifice opener from Fanta, especially the Fanta AFF1 Blue, as I told you, because of the flat side design. So back again to the files that I will use in retreatment to remove the gutta-percha in curved canals. I will use Fanta AFF1 Blue. These files are really, really, really great in retreatment and removing the gutta-percha in a curved canals or even in a straight canals. Why? Because simply they have this flat side design, and this flat side design will be very, very, very helpful in removing the gutta-percha and to give a space for the gutta-percha or even the debris or even whatever inside the canal to be pushed out, not to be pushed in or deeper inside the canal. So for me, the best to remove the gutta-percha from the inside the canal is Fanta AFF1 Blue because of the flat side design. This flat side design very helpful in removing everything from the inside the canal. Very helpful because it improved, as I said in the lecture of management of curved canals. According to this study from Gianluca, he stated that this flat side design improves the resistance to the cyclic fatigue or the flexural fatigue, and the flexibility was very, very improved and good. So for me, in straight canals, I will just use the Fanta retreatment kit, And in curved canals, I will just use Fanta AFF1 Blue. Now, the protocol. The coronal 1/3, I remove it with the first file, the 3009 from Fanta Retreatment Kit, or even with an orifice opener from Fanta AFF1 Blue. And the middle third, I will just remove it with the second and third files from Retreatment Kit, or even with 2004 or 2504 or even 3004 or even 2006, whatever the file. But for me, in retreatment cases, I prefer taper 06. It's just a personal thing. I prefer taper 06 in the retreatment cases. But you should know, and you must know, that I only use rotary files in the coronal and the middle third. So the coronal third for the bigger file, and then the middle third is for the smaller files. But what about if you have a getaburka in the apical 1/3? It's very, very, very unsafe to remove it with a rotary file, because sometimes you just push more and more getaburka beyond the apex, whatever the file design you have, because if it's not of the file design only, because of also this reaming motion. The rotation motion is a little bit pushing things. This is normal physics. So in the apical third, I remove it with H files. But you will ask me, what kind of H files? What size of H files? I will just tell you that not less than 25. Because simply less than 25 H file in such areas will be very, very, very subjected to fracture. So if you are going to remove a getaburka in the apical 1/3 with an H file, just use from 25 or 30, but not less than 25. We have a lot of methods or combination of methods to remove the getaburka, like I said, K file, H file, getaburka solvent, and rotary files, or even heat transfer device. You can use the pen to remove a little bit part of the getaburka in the coronal part of the tooth, and soft tissue laser nowadays and the rotary instrument are the very easy way to remove the getaburka and very quick way to remove the getaburka. Here is the K file and H files, and by the way, Fanta have good H files you can use to remove the apical part of the getaburka inside the canal. Now, we have a video again, and in this case, the obturation from the previous dentist was with files, but I don't know why he put H file in the mediobuccal and H file in the distobuccal, but he put K file in the palatal. I don't know why. Maybe he just finished all the H files in his clinic. Anyhow, I just entered and removed it a little with plier. I didn't use ultrasonic in this case because it's a little bit may make secondary fracture. With the plier, I just removed the files, and I did detected the MB2 canal, and then shaped and obturated. And here is the the obturation or the post-op X-ray with the MB2, and everything is fine. So from the origin, why to put files? I don't know. Honestly, I don't know. Here you can see H file in the mesiobuccal, H file in the distobuccal, and a K file in the palatal. But what about MB2? Why you didn't put a file in the MB2? Anyhow. Solvents. Please guys, do not use solvents in removing the getaburka because of two main reasons. First of all, because under magnification, you will just see nothing. The vision will be very bad and it make a mess. As I always say, it's a shitty mess under magnification. You can see nothing. And for those who don't have magnification, or even do not even realize its importance, the other reason is these solvents go inside the dentinal tubules, and then after that they hinder or prevent the irrigation solution to go inside these dentinal tubules, and it will indeed affect the irrigation, and then after that indeed it will affect the obturation. And you know in retreatment that you have a lot of resistant bacteria that you want to kill, and you want to very much to kill these bacteria and to obtain your biological objectives of the root canal retreatment. So please do not use gutta-percha solvents inside the canal if you want to remove the gutta-percha, as I told you. First, because it makes a very shitty mess under magnification and you see nothing inside the canal, and also because it goes inside the intestinal tubules and then it hinders the irrigation, and then after that indeed the obturation. Here are some kind of solvents if you are going even to use, and some of them are even carcinogenic, and I know that some are using these gutta-percha solvents. I'm not against. If you, it's up to you. For me, I don't use, and I know that in Europe it's prohibited to use chloroform, but in USA and Asia and Africa indeed nothing is prohibited. Anyhow, again we have some retreatment cases. It's time of cases. Here you can see it's a lower first molar, bad coronal seal, bad obturation, short obturation, big periapical lesion. So indeed I decided no. I made my clinical, as we said in the lecture, we make the clinical assessment, okay, we made our radiographic assessment, okay, and then I decided to do non-surgical retreatment. I removed the gutta-percha the same way as I told you exactly, and then after that I made my master cone checkup, obturation, and you can see here we have this kind of focal radiolucency, and this kind of focal radiolucency are related to this kind of lateral focal canal, and you can see it in the x-ray. Here is how I removed. First of all, when I opened, I found a lot of gutta-percha in the floor of the bulb chamber. Simply I removed it with ultrasonic, and then after that you can see even the file of the Fanta in the distal, and in the mesials I use the Fanta AFF 1 blue files. And here is 7 months, only 7 months follow-up. Here is only 7-month follow-up. And I used bioceramic sealer, as I always say, and you can see the focal radiolucency disappeared completely, and even the periapical lesion disappeared completely, and everything's fine, touching wood, thanks God. So, please guys, non-surgical retreatment is a very good treatment option if done correctly. Only if done correctly. And here is an evidence for that. Another case, second premolar, bad obturation, short obturation, periapical lesion, and you can see even there is an implant there. And then after that, after I made my non-surgical retreatment, it was very easy to remove such gutta-percha inside a straight canal the same way, and then after that you can see even the very conservative obturation. I didn't have a lateral canal, I didn't have anything, I didn't have this kind of ramification, this kind of catchy anything, but it was just I made a good shaving, I made a good irrigation, I made a good cleaning, and then after that you can see even in 1 year follow-up everything disappeared and everything's fine. Now another video here, it was very well obturated but 6 years ago, and there was a composite restoration, but the composite restoration was very bad and leakage happened in this because of the bad corona restoration. And here you can see After I removed the gutterburka, the pus started to come out from the canal. You can see the pus started to come out from the canal. Here, the patient had a lesion, had an abscess, and every time in such cases, when I remove this gutterburka, I always have this pus coming out from inside the canal. Just enjoy the video, and I just save my voice a little bit. You can see the pus coming out from inside the canal. With some gutterburka removal, I started to have more pus to come from inside the canal. Here you can see with the irrigation, you will see just a fantastic thing now. Here's pus, and then as I told you, after pus, blood come. Here you can see the blood is coming out from the embito. Yes, the embito was messed. Here is the blood coming out from inside the canal. So now pus mixed with blood. And as I told you, the abscess drainage cascade is pus, blood, and then exudate. Now, with some good question, Dr. Hatis. Was this one famous or VIP? No. She's a wife of one of my friends. And he's a dentist, by the way, and I think he is attending our lecture now. Here is the blood. After pus completely drained, you will see blood, and then after blood, you will just see some exudate after that. And indeed, here in this case, I retreated the whole system. I retreated the distal buccal and also the palatal one. All right. So another case, another very, very heroic case, because this patient came to my clinic and she asked for a restoration for her case. But if you can see in the x-ray of the left one, the upper one at the left, we have a broken file, we have a perforation related to the furcation, and also we have ledge and we have bad obturation, we have a broken file beyond the apex. If you can see it, I will show it in the prognosis even x-ray. And then I told her, okay, let's give it a chance. You can see here in the mesio root, we have this perforation, and here is the mesiobuccal and mesiolingual, and you can see another perforation where the file was there. I don't know why he did break a file in this part, and it was not in the canals, but anyhow, we all do this. Then after that, after I removed the file and I went in the mesiolingual canal, I had a ledge, and then after I bypassed the ledge, I did break a file even in the area beyond the ledge, and then I bypassed it was a very heroic case. After I bypassed the ledge, I did break a file, and then after I did break this manual file or this hand file, I did bypass to this file, and then I obturated the case. And then as you can see, after obturation of the two main canals, I put MTA in this part of the mesio root to seal any perforation there. And here is perforation, mesiolingual, mesiobuccal, and the other perforation where the file was there, and the distal root or the distal canal with the obturation, as you can see. And here is the follow-up, 1 year follow-up. In the first picture, on the left, you can see how she came to me. One broken file in the orifice, and one broken file deep in the periapical lesion, apical to the mesio root, if you can see it. Here is after obturation in the middle picture, And in the right picture, it's after 1 year follow-up, and even the other prosthetic dentist, he made this tooth as an apartment. He used it for bridge. We just trying to remove the post, but because of this amalgam restoration, we cannot remove it. And as I told you, a little bit use the coolant, do not heat or overheat. Then now I'm using this high speed pair. As I told you, with coolant will be better. And now I'm starting to remove the amalgam restoration. Around the post with the high speed handpiece, and now with the ultrasonic around the post in a counterclockwise motion, it will just start to dance. Sometimes, in such cases, in just 1 minute, the post will be removed, and sometimes it takes up to 25 or even 30 minutes to remove this metal post. I think after this lecture, now you know why we go in a counterclockwise, why we are using coolant, why we just use it for 10-15 seconds and then cool again, why you are using Fanta AF F1 Blue now as an orifice opener. This one is Fanta S4 orifice opener, and even just make this kind of drill, you will just see the whole pus coming out from inside the canal. Now I'm a little bit removing the obstruction of the guttapercha inside the canal, and you can see the pus coming out from inside the canal. But not all the guttapercha were removed. So in such, because someone asked me if I have this kind of guttapercha in the walls of the canal after removing the main part, you can just remove it with Ultra X. Ultra X is very, very good in removing this kind of guttapercha from the walls of the canal. Then irrigate again. And you can see here we have this very, very mobile part, and it was very easy even to grasp it or to remove it with